CTG Management, an approach to managing CTG concerns. Our objectives for this lecture are to formulate a management plan based on the physiological causes for CTG changes, to consider the causes of hypoxia and how to reverse them, to identify non-reversible causes and plan delivery appropriately. Finally, to consider any complicating factors. Once we have classified the CTG using our Trust's preferred guideline, we then look at applying our physiological knowledge to the situation and forming an appropriate management plan. The question we must always ask ourselves is, how is the baby? A trace may be pathological according to the classification, but the baby may be showing us signs that it's coping and does not require urgent delivery. If we can improve the situation with conservative measures, then this is by far the best option. It is therefore important to understand the physiological events behind the changes in fetal heart rate and recognise the signs of decompensation. An awareness of these features can provide reassurance to the fetal status without the need of performing further testing. However, in situations where changes cannot be explained, it is important to seek senior advice and plan further testing accordingly. According to NICE and FIGO guidelines, if the CTG parameters of baseline fetal heart rate and baseline variability are normal, the risk of fetal acidosis is low. Therefore, if there is no rise in the baseline and the variability is maintained, we can conclude that the risk of hypoxia is low and justify conservative management, even if the trace is pathological by the guidelines. It is important to document your reasoning clearly in the notes, as this is where your management plan may start to deviate from the guidelines. Good clinical judgment is required to diagnose the underlying cause for a suspicious or pathological CTG, to judge the reversibility of the conditions with which it's associated, and to determine the timing of delivery. The objective is to avoid prolonged fetal hypoxia or acidosis, as well as avoid unnecessary obstetric intervention. Additional methods may be used to evaluate fetal oxygenation, such as fetal scalp stimulation. When a suspicious CTG develops, it's important to address underlying causes before it becomes pathological. In cases of suspected hypoxia, we must identify any reversible causes, as alleviating them can lead to subsequent recovery of adequate fetal oxygenation and the return to a normal trace. If any non-reversible causes are identified, delivery must be expedited. Firstly, let's remind ourselves of the types of hypoxia, how to recognise them, and their common underlying causes. Chronic hypoxia is due to uteroplacental insufficiency or antenatal insults. These CTGs have a higher than expected baseline, with shallow decelerations and often reduced variability. It is important to remember that these babies have a reduced physiological reserve and therefore a reduced ability to compensate for any further hypoxic stress. These babies may deteriorate rapidly with further hypoxic insult. Gradually evolving hypoxia is due to hypoxic stress as a result of prolonged, overly frequent or overly strong contractions. There will be repetitive decelerations, followed by a rise in the baseline, with a subsequent loss of variability. These babies are demonstrating an ability to compensate for hypoxic stress. However, after a prolonged period, these babies will run out of reserve and start to decompensate. Subacute hypoxia is where the baby spends less than 30 seconds at the baseline and more than 90 seconds in deceleration. In this situation, the baby is prioritizing protecting the heart and spending only 1/3 of the time at the baseline for gas exchange and to oxygenate the brain. In this state, acidosis rapidly develops with a drop of pH of 0.01 every 2 to 3 minutes, and therefore immediate action is required. This type of hypoxia is often due to hyperstimulation or pushing in the second stage. Acute hypoxia manifests as a single prolonged deceleration, less than 80 beats per minute, for more than 3 minutes. In this situation, we need to exclude the 3 obstetric non-reversible accidents, which are abruption, cord prolapse, and uterine rupture. Once these are excluded, we can look at reversible causes such as hyperstimulation, maternal hypotension, and cord compression. We will start by looking at some reversible causes of hypoxia. Excessive uterine activity, or hyperstimulation, is the most frequent cause of hypoxia. It is important to note that hyperstimulation depends not only on the frequency of the contractions, but also their strength and duration. If the baby is not coping or does not have sufficient time at the baseline to recover in between contractions, then this is hyperstimulation. Hyperstimulation can usually be reversed by removing administered prostaglandins, reducing or stopping oxytocin infusion, and starting acute tocolysis. During the second stage of labour, maternal pushing efforts can also contribute to fetal hypoxia, and the mother can be asked to stop pushing until the situation has improved. If this does not improve the trace, delivery should be expedited. It's worth noting that due to the longer half-life of prostaglandins, hyperstimulation in this context usually requires the removal of the propes and administration of tocolytics at the same time, especially when dealing with acute hypoxia. When using oxytocin in labour, continuous electronic fetal monitoring is necessary. If the fetal heart rate is normal, oxytocin should be titrated to achieve contractions at a rate of 4 in 10, and it should be reduced if they occur more frequently than 5 in 10. If the CTG is suspicious, a review by a senior staff member is needed to confirm there is no evidence of hypoxia, and a plan of action should be discussed and documented. If the fetal heart rate is pathological with evidence of fetal hypoxia, an urgent assessment of the fetal condition should be undertaken and documented by an obstetrician. The syntocinon should be reduced and tocolysis considered if there is no improvement. In the case of acute hypoxia, oxytocin should be immediately stopped and a 3-minute rule initiated. Aortocaval compression is another reversible cause of hypoxia. This can occur in the supine position. Turning the mother to lateral or upright positions may relieve the compression and improve the trace. In transient cord compression, there will be variable decelerations. These can sometimes be relieved by changing maternal position. Sudden maternal hypertension most frequently occurs after a spinal or epidural anesthetic. This results in a sudden drop in the maternal blood pressure. There is a redistribution of maternal blood away from the placenta, which results in inadequate placental perfusion. It will present as a single and sudden drop in the baseline rate, or acute hypoxia. In this instance, it is reversible and should be corrected by maternal positioning and IV fluids. Vasopressors can also be given if appropriate. In a well-oxygenated mother, there is currently no evidence that oxygen administration is of benefit in fetal hypoxia. the evidence suggests this may actually be harmful. A Cochrane review found 2 trials which addressed prophylactic oxygen administration during labour. Abnormal cord blood pH values were recorded significantly more frequently in the oxygenation group than in the control group. Additionally, there is no good clinical evidence that the administration of IV fluids in a normotensive, well-hydrated woman is of any benefit. We will now look at the non-reversible causes of hypoxia. In the case of acute hypoxia, there are 3 major accidents that must be considered and excluded. In this situation, delivery must be expedited as these accidents are irreversible. These are abruption, uterine rupture, and cord prolapse, which all present with acute hypoxia. They are irreversible and delivery must be expedited. There are some other factors to consider when making a management plan. We will cover these in more detail in another tutorial, but briefly we will touch on meconium and pyrexia. Meconium is associated with cerebral palsy, chorioamnionitis, and meconium aspiration syndrome. The rate of cerebral palsy is twice as common in term infants with meconium than in infants with clear liquor. In preterm infants, the cerebral palsy rate is 4 times more common in the presence of meconium than in clear liquor. Therefore, extra vigilance should be taken to observe for signs of hypoxia in the presence of meconium, and a lower threshold for expediting delivery should be considered when there is thick meconium and signs of hypoxia, as these babies will not cope with hypoxia as well as babies where there is no meconium. Pyrexia. In chorioamnionitis, there is a 5-fold increased risk of cerebral palsy. If we combine pyrexia and hypoxia, there is a 78-fold increase in the risk of cerebral palsy. It's worth noting that the fetal temperature is between 0.3 and 0.6 degrees higher than the maternal temperature. Intrapartum fever is also associated with a 4-fold increase in the risk of unexplained early onset seizures in term infants. In pyrexia, the metabolic demands of the fetal tissues are increased, and so the risk of hypoxia is elevated. We should therefore treat any pyrexia and infection with paracetamol, IV fluids, and IV antibiotics. We will now look at tocolysis, starting with terbutaline, which is given in a dose of 250 micrograms subcutaneously and may be repeated in 15 to 30 minutes according to the response. The maximum dose is 0.5 milligrams every 4 hours. There are some adverse effects to be aware of, which include restlessness, transient hyperglycemia, transient hypokalemia, tachycardia and palpitations, dizziness, nausea, and an increased fetal heart rate. Terbutaline has some drug interactions, and therefore caution should be taken with tricyclic antidepressants and corticosteroids. When terbutaline is given, maternal blood pressure and heart rate must be monitored. We should also monitor glucose and lactate levels in any diabetic patients, as terbutaline may cause hyperglycemia. We must also keep an eye on fluid balance in preeclampsia, multiple pregnancy, and maternal infection. Terbutaline is contraindicated in the following situations: pre-existing ischemic heart disease, placental abruption, pulmonary hypertension, hypertrophic obstructive cardiomyopathy, or any left ventricular outflow obstruction. Caution should also be exercised in thyrotoxicosis. However, terbutaline can be used in situations of cord prolapse in order to relieve pressure on the cord. Terbutaline will have an effect on the fetal heart rate, and it's important to understand the mechanism by which this happens and the pattern that you're expecting. There will be a baseline rise in place already due to the hypoxic stress. We then give terbutaline, which will in theory cause a further rise in the baseline. However, as the hyperstimulation reduces, the catecholamine levels released by the fetus will also reduce. Therefore, the baseline rate should either stay the same or start to reduce. Do not be alarmed if the baseline does not immediately start to reduce, as this is likely due to the effect of the terbutaline. However, if the baseline continues to rise, this suggests the hypoxia is not improving, and therefore further management needs to be commenced. We will now look at GTN, which can be given 400 micrograms as a slow IV injection. GTN requires a hemodynamically stable patient, as it can cause hypotension. This can result in placental hypoperfusion and therefore acute hypoxia, and therefore we must use this drug with caution. It is contraindicated if there is a known allergy to nitrates, any signs of acute circulatory failure, severe hypotension, arterial hypoxemia, any uncorrected hypovolemia, and angina caused by hypertrophic obstructive cardiomyopathy. It is also contraindicated in cardiogenic shock, severe anemia, and toxic pulmonary edema. When comparing the two agents, no difference has been found between GTN and terbutaline in a successful intrapartum fetal resuscitation. Terbutaline has been shown to provide more effective tocolysis with less impact on maternal blood pressure, and therefore this is the recommended drug of choice. We will now move on to look at the management algorithms for each different type of hypoxia. In acute hypoxia, we follow the 3-minute rule. Once a prolonged deceleration has occurred for longer than 3 minutes, the emergency buzzer is pulled, and if the patient is not on the labour ward, a Category 1 caesarean section call should be put out, and the lady should be transferred to theatre. Between 3 and 6 minutes, the mother is attended by the team on labour ward and assessed for one of the 3 intrapartum accidents. If one of the accidents is identified, immediate delivery should be commenced. Once the accidents have been ruled out, we look for one of the reversible causes and give immediate treatment. If after 6 minutes there is no sign of recovery, we must consider we may have missed one of the accidents and arrange for immediate delivery. Between 9 and 12 minutes, the lady should have been transferred to theatre, and if the deceleration has recovered, we will observe her in theatre for 20 minutes, and if everything is normal, we can return her to the labour ward. If the deceleration has not recovered, between 9 and 12 minutes we will make preparations for operative delivery or caesarean section, and between 12 and 15 minutes, the baby should be delivered. Please note that if the variability is reduced before the start of the prolonged deceleration or within the first 3 minutes, this baby needs urgent delivery. Subacute hypoxia, where it is caused by hyperstimulation in the first stage, where contractions of more than 4 in 10, or any number of contractions where the fetus has not got adequate rest time to recover. We remove propes or stop syntocinon if relevant, and consider terbutaline. Where subacute hypoxia is due to excessive pushing with inadequate rest time in between contractions in the second stage, we can ask the patient to stop pushing for 2 contractions to see if the fetus recovers. If there is no sign of recovery, at this point we consider terbutaline. We could also consider IV fluids and a position change. If the subacute hypoxia is still not improving, it's at this point we should consider expediting delivery. If the hypoxia improves, we can continue pushing as long as there is adequate rest time between contractions. If necessary, you can consider pushing with every other contraction or allowing occasional breaks. In gradually evolving hypoxia, there will be decelerations, which represent a compensated stress response. You can consider a position change. As the decelerations become wider and deeper, which still represents a compensated stress response, we can consider a senior obstetric review and continue conservative measures such as position changes and relieving stress. We can remove a propes if one is inserted or turn down the syntocinon. As the hypoxia worsens, there will be loss of accelerations. There will then be a rise in the baseline. Again, this represents a compensated stress response. At this point, we should consider turning off the syntocinon and giving terbutaline. We can try position change and IV fluids if this is not tried already, and use other adjuncts to confirm fetal well-being, such as fetal scalp stimulation. After the rise in baseline, there will be a loss of variability. This is where the fetus is starting to decompensate and is starting to shut down the brain in order to conserve resources for the heart. At this point, we need to consider the bigger picture, whether there is meconium, any evidence of pyrexia or chorioamnionitis. We consider the uterine scar, the rate of progress, and the use of oxytocin. If we are unable to improve the situation, we must consider delivery at this point, because the next stage is heart failure. To summarize, in cases of suspected hypoxia, we must identify any reversible causes and address them promptly in order to improve the CTG. If any non-reversible causes are identified, immediate delivery should be undertaken.